Hello, and welcome to the Electrolyte Club. My name is Helbert Rondon, and I am a nephrologist at the University of Pittsburgh. This is lecture number 5, Pathophysiology and Etiology of Hypotonic Hyponatremia, Part 3. The learning objectives for this lecture are: number 1, to explain the pathophysiology of hypotonic hyponatremia due to SIADH and cortisol deficiency. Number 2, describe the key clinical features of hypotonic hyponatremia due to SIADH. Number 3, list the diagnostic criteria for SIADH. And number 4, list the pathophysiological mechanisms causing hypotonic hyponatremia from high ADH. We're going to start with the case scenario. This is a 63-year-old man with a past medical history of tobacco use for 40 years who comes to the emergency room with muscle weakness. The patient reports his muscle weakness improves slightly with activity. His review of system is significant for weight loss and dry mouth. On exam, blood pressure is 130/56, heart rate is 89, there is no jugular venous distension, lungs are clear to auscultation, there is no peripheral edema, however there is claving present, and the urine output is about 1.4 liters per day. The chest x-ray shows a right upper lobe mass. And these are the labs. The sodium is 121, potassium is 4.3, calcium is 9.8, magnesium is 2.6, urine osmolarity is 645, urine sodium is 153, and urine potassium is 67. So the question is, what is the most likely cause of hyponatremia in this patient? Letter A, cell wasting nephropathy. Letter B, primary polydipsia. Letter C, hypovolemia. Or letter D, SIADH. And the correct answer is letter D, SIADH. So how does the hyponatremia from SIADH occurs? So initially we have our patient with normal total body sodium, normal total body water, and they are maintaining a normal proportion between sodium and water. And then unfortunately this patient develops lung cancer, let's say, small cell, and start to produce ADH. If the patient is drinking water or hypotonic fluids, then he's going to retain water, and now the total body water will be more than the total body sodium, causing hyponatremia. However, this cannot go indefinitely. After about 5 days or so, the kidneys start to become refractory to the actions of ADH. Aquaporin 2 is downregulated. So this is called ADH escape mechanism, and the total body water that was initially high is going to be reduced a little bit. Now on the other side, because there was an initial water retention, that's going to cause mild volume expansion, which will decrease activity of the RAS system, of the renin-angiotensin-aldosterone system. So there will be less aldosterone, the kidneys will not be able to hold onto sodium, so they will start dumping sodium in the urine, and the urine sodium will go up. This natriuresis that occurs as a compensation from the initial volume expansion from water reabsorption is called compensatory natriuresis, and that will make the total body sodium to go down a little bit. So at the end of the day, in patients with SIADH, total body water is high, total body sodium is low, and because of that, the clinical assessment of the volume reveals that the patient is euvolemic, right? Because they have total body sodium low but total body water high. So they are actually, if you measure it more precisely, they might be mildly volume expanded, okay? But clinically you cannot perceive that. Clinically they look euvolemic. So what are the key features of hyponatremia from SIADH? The urine osmolarity will be more than 100 because there is too much ADH. Because these patients have compensatory natriuresis from mild volume expansion, the urine sodium will be high, more than 30, and they will be euvolemic clinically. Total body water is high but total body sodium is low, so at the end they cancel each other out. They are euvolemic clinically. What are the diagnostic criteria for SIADH? So they have hypotonic hyponatremia, they are euvolemic, the urine osmolarity is high, more than 100, the urine sodium is high, over 30, the plasma uric acid is less than 4, and the reason for that is because the proximal tubule reabsorbs uric acid, and it reabsorbs more when there is volume depletion. When the patient is mildly volume expanded, they won't reabsorb as much uric acid, so the patient has a high excretion of uric acid, and the plasma sodium will go down. usually the plasma serum uric acid will go down, so less than 4 usually. And the other criteria is that the patient has to have a normal kidney, adrenal, and thyroid function. So you cannot diagnose SIADH in the presence of CKD or end-stage renal disease. And it makes sense. You could have a lot of ADH in your system, but if the kidneys are damaged, they're not going to respond to ADH, right? So that makes sense. Adrenal insufficiency can mimic SIADH if you're not careful to check certain things. And thyroid problems can cause hyponatremia only when they are severe. When the TSH is very, very high, hypothyroidism might be related to hyponatremia, but TSH that is 10 or 20 is not going to do much. It's not gonna. That's not a reason for hyponatremia. So it has to be very, very, very high, the TSH, more than 50 to 100 at least, to cause hyponatremia. So, but you have to rule it out because there is no way to tell unless you check it. What are the main causes of SIADH? So we have 4 groups of causes. The number 1 cause is CNS disease, central nervous system problems, infections like meningitis, encephalitis, brain tumors. Okay, and it makes sense because in our brain we have the main centers for production of ADH, right? The supraoptic nuclear paraventricular nuclei, and we have osmoreceptors. So if something is interfering with that, ADH could be produced in large amounts. Second group of causes is pulmonary problems like infections such as pneumonia, tumors, lung cancers, and certain cancers such as the small cell actually produce ADH directly. The cells produce ADH. Pneumothorax, pleural effusions. The reason for this, it's thought because the increase in intrathoracic pressure will decrease the venous return and the effective blood volume will be low and the baroreceptor will be activated. Experimentally has been seen that when intrathoracic pressure increases, your baroreceptor gets activated, right? So anything in your chest will activate it because the baroreceptors are in the chest, the carotid bodies and aortic arc. So they will activate ADH and will cause SIADH. The third category is drugs. And the first type of drug is antidepressants. And the main type of antidepressants associated with SIADH are SSRIs. So be careful about those medications. But there is a long list of medications that can cause SIADH, so you have to go and review the medication list to make sure the patient's medications are not on that list. And finally, the last category is miscellanea or other. And the main 2 things there are nausea and pain. Nausea and pain are very potent stimuli for ADH. So you have to address those as well. Now, what about hyponatremia from cortisol deficiency? And that's one of the main differentials for SIADH. So what happens? So we have our hypothalamus that produces CRH, and that will act over the pituitary. The hypothalamus also produces ADH, okay, and the CRH will stimulate the pituitary and produce ACTH, which will work on your adrenal gland to produce cortisol. It turns out that cortisol inhibits CRH and also inhibits ACTH. It establishes a negative feedback, all right? But also cortisol inhibits ADH production by the hypothalamus. So when you have cortisol deficiency, then ADH is uninhibited and it will be producing larger amounts, causing hyponatremia. Now, there are 3 causes of cortisol deficiency. We have primary adrenal insufficiency when the problem is the adrenal gland. We have secondary adrenal insufficiency when the problem is the anterior hypophysis. And we have tertiary adrenal insufficiency when the problem is the hypothalamus. So, in secondary and tertiary adrenal insufficiency, the problem is just that there is no cortisol and therefore ADH will be uninhibited. However, in primary adrenal insufficiency, there is a double reason why to develop hyponatremia. Number 1, there is no cortisol. But number 2, remember, adrenal gland also produces aldosterone. And when you don't have aldosterone, then your kidneys cannot retain sodium and you'll dump sodium in the urine and you will develop eventually hypovolemia because of that. And hypovolemia will be a second stimuli for ADH to be produced. So for primary adrenal insufficiency, 2 reasons to have hyponatremia. Number 1, no cortisol. Number 2, no aldosterone. Okay. Now, just to review what already we have talked about, there are three main mechanisms by which hyponatremia from high ADH can occur. Number one, decreased effective arterial blood volume, and we'll review this in lecture number 4. And in this lecture, we're reviewing the two other mechanisms, which is SIADH and cortisol deficiency. Those are the three main mechanisms. So, reviewing everything together, hypotonic hyponatremia is always a free water excess problem, and there are two reasons for this. Either you are drinking too much water, exceeding the maximal renal excretory capacity, or your kidneys cannot get rid of the water. And what are the three main reasons for that is high ADH, low solute intake, and low GFR. And what are the three main reasons why ADH could be high? Low effective arterial blood volume, SIADH, and cortisol deficiency. So what are the take-home points? Hypotonic hyponatremia in SIADH occurs not only due to a dilutional effect, but also from renal sodium loss. Hypotonic hyponatremia in cortisol deficiency occurs because of loss of negative feedback of ADH release. The key clinical features of hypotonic hyponatremia from SIADH are clinical euvolemia, high urine osmolarity, and high urine sodium. The diagnosis of SIADH can only be made in the presence of normal renal, adrenal, and thyroid function. And finally, hypotonic hyponatremia due to high ADH is caused by decreased effective arterial blood volume, SIADH, or cortisol deficiency. Thank you for your attention.